Hello everyone, this is Dr. Shiwani Chaturvedy and this lecture is about the history of cataract surgery. Also, I will discuss the steps of SICS in brief. So let's begin. The earliest known cataract surgery is couching, which was first practiced in India around 206 BC, and it is also called lens depression, where the cloudy lens is pushed out of the visual axis, and it involves using a sharp instrument to displace the lens to the bottom of the eye, and this procedure was done without the modern tools like microscope, making it very risky, and the patient were left aphakic. After that, there was intracapsular cataract extraction, which was first performed by Samuel Sharp in London. And this technique involved making a large incision at the limbus and removing the entire lens along with its capsule. And it was a standard method for about a century before advanced techniques were developed. Over the time, it was largely replaced by extracapsular methods, which are safer and more precise. Today, intracapsular cataract extraction is rarely used and it is mainly reserved for cases with severely subluxated or dislocated lenses. Here comes extracapsular cataract extraction, which was first performed around 1747, and in this technique the cataract is removed while leaving the posterior capsule intact, and this allows the placement of posterior chamber intraocular lens within the capsular bag and improving the visual outcomes. Extracapsular cataract extraction marked a major advancement over the ICCE by being safer and more anatomically preserving option. Over the time, it evolved into modern techniques like conventional extracapsular cataract extraction, small incision cataract extraction, phacoemulsification, and femtosecond laser assisted surgery that I'll discuss later. Now moving on to small incision cataract surgery, which is widely used technique especially in resource limited settings. It is a method of extracapsular cataract extraction along with implantation of PCIOL. The key feature here is that it is done through a self-sealing sclerocorneal tunnel incision, and this sutureless approach reduces the surgical time, promotes healing, and minimizes complications related to sutures. SICS is particularly important in developing worlds where high patient volume and limited resources make cost-effective and efficient techniques essential. And the modern form of SICS was first described by Dr. Ruitt in 1999, and it has since transformed cataract care in many parts of the world. Now, after that, phacoemulsification, which was introduced by Charles Kalman in 1967, revolutionized cataract surgery, and it allows cataract removal through a small 3 mm incision, reducing the complications and speeding recovery. The lens is broken down using ultrasonic energy. The energy was generated by piezoelectric crystals, converting electrical energy into vibrations. Along with this, first intraocular lens was developed by Harold Ridley, which further improved the visual rehabilitation. Overall, phacoemulsification represents a major shift towards minimally invasive, faster and safer surgery. Moving on from traditional phacoemulsification, we arrive at the latest evolution, that is FLACS, femtosecond laser assisted cataract surgery. The FDA approval of FLACS in 2010 introduced a new level of computer guided precision to the operating room, and the magic behind this technology is femtosecond laser, and which works on the principle of photo disruption. Now, the laser automates several critical steps that in the cataract surgery, and the first one is that it creates incredibly precise multiplanar architect for the main entry wound, which helps to seal it better, also used to correct pre-existing astigmatism during the cataract procedure. And the most impressive part is that the laser creates a perfectly center circular opening in the lens capsule, and before the surgeon even enters the eye with a phaco probe, the laser has already pre-chopped the cataract into the small cubes, making the removal easy and gentler. Cataract surgery has evolved tremendously from basic techniques in the past to refined microsurgical procedures today, and with current advances, we achieve better safety, precision, and visual outcomes. History part. Coming to the SICS procedure, I will be discussing in brief about each step. So, to begin with, we first place a bridal suture, We typically use 5-0 silk suture passed directly beneath the insertion of superior rectus muscle, and precision is the key here. The insertion point is approximately 7.7 mm from the limbus. If you look at the diagram on the right, you can see the relationship between the limbus and the various muscle insertions. And now, why do we do this? Because it facilitates the downward rotation of the globe and providing a much better view and more working space in the superior surgical field. Also, it helps stabilize the eye during the initial incisions, and later in the surgery, it provides the necessary counter traction to aid in the smooth delivery of the nucleus. While the bridal suture is a routine step in SICS, it is not without risk, and the most serious risk is globe perforation. If the needle is passed too deeply, there is risk of perforating the globe, which can lead to vitreous hemorrhage, retinal detachment, or endophthalmitis. So always ensure a superficial and controlled passage through the muscle tendon. And also, superior rectus is a vascular structure, so accidental trauma can lead to some conjunctival hemorrhage or localized hematoma, which is usually self-limiting. And if the suture is handled too aggressively, we can risk muscle laceration or in extreme cases avulsion of the superior rectus muscle, which can lead to significant post-operative mobility issues or diplopia. And occasionally suture may cheese wire through the muscle or may be placed too loosely, so a failed bridal suture, which results in poor globe stabilization or inadequate exposure. And finally, we must be aware of post-operative ptosis, which is because of the excessive traction on the superior rectus muscle or unintended trauma to the surrounding muscles. Following the bridal suture, we proceed to the conjunctival peritomy. Our preference is a small fornix-based conjunctival flap, typically extending from 11 o'clock to 2 o'clock position. This provides adequate exposure for the upcoming scleral tunnel while minimizing the tissue trauma. Once the flap is created, it is common to encounter bleeding from the episcleral vessels. For that, we apply moderate intensity cauterization to manage this. And the goal is clear, dry surgical field to ensure high visibility for the subsequent steps. Also important to remember that avoid excessive cautery, because over cauterization doesn't just damage the episclera, it can cause shrinkage of the underlying scleral tissue, and this can cause post-operative astigmatism. Now following that, coming to the sclerocorneal tunnel construction, one of the unique feature of SICS tunnel is its trapezoidal shape. Notice that the external incision is intentionally shorter than the internal one. This design creates scleral side pockets, which is highlighted in yellow in the diagram. These pockets are essential because they allow the tunnel to stretch and accommodate a large hard nucleus without tearing the tissue. And the dissection technique, once the initial external incision is made, we use a crescent knife to begin the dissection, and the dissection is done with wriggling movement. You must lift the heel of the blade while keeping the tip down as you move towards the limbus. This ensures you stay in the correct mid-scleral plane. This is a crucial tip. And also, while entering the clear cornea, as the knife reaches the limbal area, you change the angle. The tip of the crescent is lifted up to follow the natural curvature of the cornea. And we continue this dissection approximately 1.5 to 2 millimeters into the clear cornea. This corneal valve is what makes the wound self-sealing later. Now this slide outlines the key aspect of an SICS tunnel in cataract surgery. The shape of the external incisions can be frown, smile or straight. Frown is most commonly used due to better astigmatism stability, and for size typically it is around 6 to 7 mm depending on the cataract hardness, and must be large enough to safely remove the nucleus. Usually placed superiorly or superotemporally, about 1 to 1.5 mm behind the limbus, and about 1/3 to half of the it is about 1/3 to half of the scleral thickness. Too shallow can risk in buttonhole, and too deep can cause premature entry or scleral damage. Overall, proper design of incision helps to ensure wound stability and better surgical outcome. Must keep these points in mind that we should maintain a constant plane throughout and always follow the natural curvature of the incision for a smooth tunnel. And at the ends, extend the dissection obliquely backwards to form proper side pockets. And also the blade should be just visible during the dissection. This indicates correct depth. And always remember, if it is too clearly visible, it is too superficial. And if it is seen very hardly, it is too deep. So proper technique ensures a well-formed self-sealing tunnel. Now for side port is usually made at 9 o'clock just inside the limbus, keeping the blade parallel to the iris. And for entry into the anterior chamber, a 2.8 mm angled keratome is then advanced through the tunnel carefully, avoiding damage to the roof and the floor. And once at the inner end, tilt the tip downwards to create a corneal dimple and gently enter the anterior chamber. Ensure entry is smooth and controlled to prevent complication. After entry, continue parallel to the tunnel plane and use only forward movement to avoid irregular internal wounds. Now coming to capsulorhexis, which is usually performed as continuous curvilinear capsulorhexis using a cystitome or utrata forceps. A cystitome is made from a 26 gauge needle with two bends, one 90-degree tip bend and an opposite bend near the hub for control. After filling the anterior chamber with viscoelastic, we start with the central puncture in the anterior capsule and raise a flap and progressively move in a small arcs, usually 1 to 2 clock hours, maintaining control. And we aim for about 6 mm of rhexis and complete the rhexis with a controlled outside-in movement to maintain a smooth circular edge. Now some key points regarding capsulotomy. The first one is always maintain a deep anterior chamber. Shallowing of AC can cause rhexis run out, and in cases of rhexis run out we must be aware of Little's technique. That is, first we fill the AC with viscoelastic and grasp the flap and pull it backwards to redirect it centrally. And if also we can use Vanna scissor to cut and redirect the tear, and alternatively we can complete it using a can opener technique if needed. And also remember that a small rhexis can be enlarged with radial relaxing incisions. The key idea here is to stay controlled and redirect early to avoid complications. Now coming to two alternative capsulotomy techniques, which are can opener and envelope technique. Can opener technique is easy to learn and perform. Multiple small tears distribute forces and reduces the risk of radial extensions. However, it creates irregular capsular tags, making cortical cleanup difficult. An envelope technique is simple and efficient, especially useful in mature intumescent cataracts where CCC is difficult but carries a risk of anterior capsule tear and possible PC rupture, and may also result in incomplete IOL optic overlap. Overall, both are useful alternatives when CCC is not feasible. Moving on to hydrodissection, which is separation of lens cortex from the capsule, which facilitates the nuclear's mobility. It is performed using 2 ml syringe with cannula inserted under the rhexis edge. We slightly tend the capsule and advance the cannula towards the equator and inject fluid slowly and steadily to create a visible fluid wave, and this wave helps separate the corticonuclear mass from the capsular bag. And very important, proper hydrodissection ensures easy nucleus rotation and safer surgery. Moving on to hydrodelineation, which creates the cleavage plane between epinucleus and endonucleus, helps divide the nucleus into layers. The cannula is introduced into the lens substance here and advanced until the resistance of the hard nucleus is felt, then slightly withdrawn. And fluid is injected in small controlled pulses to achieve separation. A key sign of success here is golden ring seen at the nuclear edge, especially useful in posterior polar cataracts as the epinucleus acts as a protective cushion here. In soft cataracts, multiple cleavage planes may form easily, but in hard cataracts, a clear plane may not always be visible. Overall, it facilitates safer nucleus management and reduces the stress on the posterior capsule. Some important points to remember, that is, any compromised rhexis requires extra caution during the further step. Also use gentle central tapping during the hydrodissection to decompress the capsular bag and prevent posterior capsule rupture. Also, hydro procedures are not needed in hypermature cataract due to liquefied cortex. An inadequate hydrodissection makes the nucleus manipulation very difficult later, and also avoid hydrodissection in posterior polar cataracts due to high risk of capsular rupture. Now moving on to nucleus management part, which is divided into two parts. The first one is prolapsing the nucleus into the AC from the bag, and the second is delivering the nucleus out of the AC. So here we discuss the prolapsing the nucleus into the anterior chamber, which can be done by three techniques. The first one is hydroprolapse, which is done at the end of the hydrodissection. One pole of the nucleus is prolapsed out of the bag and then engaged with Sinskey hook and rotated in cartwheel fashion to bring the nucleus into the anterior chamber. It can also be done using viscoelastic to gently push the nucleus out of the bag, and also it can be done using bimanual technique, which utilizes two instruments for controlled prolapse. And once the nucleus is in anterior chamber, the nucleus can be delivered out through the tunnel safely. Now this slide covers different techniques for nucleus delivery after the prolapse into the anterior chamber. The first one is irrigating vectors technique, which uses fluid assisted support to lift and deliver the nucleus safely. And the second one is phaco sandwich technique, in which nucleus is held between two instruments and extracted in controlled manner. Then comes phaco fracture technique, in which nucleus is mechanically divided into smaller pieces before removal. Now then comes modified Blumenthal technique, which combines vectors with irrigation for smooth delivery. And then there is fish hook technique, where there is a hook which engages and pulls the nucleus out through the tunnel. And then also there is visco expression, in which viscoelastic is used to push the nucleus out gently. Choice of technique depends on the hardness of the nucleus, incision size and surgeon preference. Our goal here is safe delivery with minimal stress on cornea, capsule and the endothelium. Wire vectors technique. Firstly, we inject viscoelastic above and below the nucleus to protect the corneal endothelium and the capsule, and then we insert the irrigating vectors under the nucleus, engaging about upper 1/3 to half. As the nucleus reaches the tunnel and engages the inner lip, we apply posterior lip depression and gentle traction if bridal suture is used. Simultaneously, inject the fluid slowly to assist the delivery. The mechanism involves hydrostatic pressure plus mechanical support, allowing the smooth nucleus delivery. To cortical aspiration. Anatomically, cortex has anterior layer under the rhexis and has a posterior layer over the capsule, with bulk in the capsular fornix. It is performed using Simcoe's cannula, applying controlled aspiration. Always start by engaging the anterior cortex first and use gentle side to side movements to peel and strip the cortex from the capsule. Now key point here is thorough yet gentle aspiration ensures a clean capsular bag and better visual outcomes. After a good cortical cleanup, we move to IOL implantation. We typically use a rigid PMMA lens with 6 mm optic. First, we fill the capsular bag with viscoelastic to maintain space and protect structures, and then hold the IOL with McPherson forceps and insert it into the anterior chamber and advance until the leading haptics reaches the rhexis margin. Then gently tilt downward to place it into the bag. We typically use Sinskey hook to guide and rotate the trailing haptics into the bag. Usually downward and clockwise movement is used. Also ensure proper positioning and confirm the stretch lines on the posterior capsule, indicating correct placement in the bag. Now key point here is controlled incision and correct haptic positioning to ensure stable when centered IOL implantation. After IOL implantation, we wash out all the viscoelastic from the anterior chamber and the capsular bag and then hydrate the side ports to ensure proper sealing. And usually most cases are self-sealing, so sutures are usually not required. And also always check wound integrity with a gentle corneal tap, and sutures may be needed in specific situations in cases of premature entry, buttonholing or leaking wounds or pediatric cases. Always ensure a secure leak-proof wound to prevent post-operative complications. Now for better understanding, I am adding a SICS video. Please go through it to revise and reinforce the steps we have just discussed. Thank you.